so I know to start introductions. Okay, I've been given thumbs up by Faye in the back there. Good afternoon, everyone. It's a nice little surprise gathering to have you all on a, typically we gather on Monday, weekly research rounds or for cardiac rehab. So it's lovely to really be gathering today. We have Professor John Buckley here joining us this week and his PhD student next week here at the Ottawa Heart Institute as visiting scholars for a research project. So why don't we start off with some introductions, some formal introductions. We know, John, we welcomed Professor Buckley last year as part of our Rehabilitation Round series, but as I mentioned, we have the honor of hosting him here this week and a few days into next week. So to not cut into his time for presentation, we'll do some formal introductions here, then let him take the stage. So John is currently a professor of exercise rehabilitation at Keele University. He's been a founding committee member and of a number of national and international societies, including BACPR, which is the British equivalent of the Canadian Association of Cardiovascular Prevention and Rehabilitation, of the Exercise Professionals Group in 2001, to the BASES Division of Physical Activity for Health in 2004, the International Council of Cardiovascular Prevention and Rehabilitation 2012, and the Clinical Exercise Physiology UK's AHCS Accreditation Steering Group in 2018. He has over 25 years of frontline experience in working in physical activity for health and exercise rehabilitation, linked with several hospitals and primary care services in the West and North Midlands of the UK. He is Canadian, so if you do speak to him, don't be misguided because he is a Canadian despite his strong accent that he holds. He has experience performing over 10,000 hours of individual patient functional activity assessments, which has underpinned his research since the late 90s. This experience is directly linked with his internationally recognized research and educational publications, including International Olympic Committee Handbook of Sport and Exercise Cardiology and the World Health Organization's guidance policies on rehabilitation and ischemic heart disease. Since 2015, he has collaborated with CACPR on a number of initiatives and researchers with UBC, York University, and of course, here our home, the University of Ottawa Heart Institute. So today we have those joining us in person and also online for his presentation. I will ask at the end of the presentation, those that are in the room, we're just going to, raise your hand and we'll find the mic so that those online can hear your questions. And then those online, we will, of course, be monitoring the online platform to be able to answer your questions following his presentation. Okay, without further ado, I'm getting the nudge here. Get off, stop introducing me so I can get to the data and the research. So let's give him a warm Ottawa welcome again. Up to the stage, Dr. Buckley.
Thank you. I'll probably give him Karen. Free beer will get you anything. Free beer will always get you. Okay. I have a mic. All right. I think you got it. All right. Okay. Yeah. Do not get a sort of logo on the front that says President of or something like that. Put my press secretary in. Anyways, thank you very much for the invitation and the introduction and meeting all of you and spending time. It's great. It's next door in the exercise center, rehabilitation center, and it's been fun so far, especially meeting some of the patients. I think just it's really important to acknowledge the various people, why we're here or why I've had the opportunity to come. First of all, this comes off the back of a BACPR research development grant to be able to travel to you. It wasn't really for me. I just snuck in behind my PhD student, Sam, who you'll meet next week. And he's coming along as part of his PhD development program. I'm just a warm-up act this week. But in terms of the various people involved, obviously Jennifer the Jennifers, Jennifer Reed, Jennifer Harris, and Mateus, who've done lots of work in the background to make this happen. And then obviously some of the collaborators you'll know from here at Ottawa. And then some of my collaborators at Keele University, which is in Stoke-on-Trent, where they make china. So if you've got Spode or what is it, Wedgwood, or any of that stuff that comes from, that's what we're famous for. Our football team is rubbish. In fact, so some of the data that I'm going to share with you today is from some of our master students, Kevin, Emily, and Bindi. Kevin and Emily have just graduated with their masters in physiotherapy and have become chartered physiotherapists. And Bindi is a third-year rehab and exercise science student. So I'm going to be using some of their data, plus my colleagues in our Institute of Sport, Claire. You'll meet Sam and Dean and Steve. So why do I have pictures of space? I like space. But if you go back to the acknowledgements, there's two factors in there. One is that there's a reasonable amount of youth in there, and the majority of them are women. And those are the two factors that got man to the moon, youth and women. And so it's always nice to come along and work with these people. Youthful synapses, I think, is the average age of an engineer or a scientist working for NASA to put Neil Armstrong on the moon was 26. So that's always, remember that people are always at the peak of their abilities between 25 and 30. Whether you're an athlete, a musician, an artist, everything happens. So I try and remember that and ask for help. But the women thing is really interesting. There weren't very many women working at NASA, but there was about 4 of them that man wouldn't have got back from the moon without women. So if you've seen Apollo 13, the calculations that got them around the moon and back was from Poppy. And Katherine Johnson, you'll see that you've seen the movie Hidden Figures. It's a great movie if you want some inspiration, but she was doing the calculations for re-entry. So, or else the spacecraft would have just burned up as they hit the atmosphere. So, you know, all these men and a few key women to make things happen. So what's new? But now there's lots of women here at the Heart Institute doing wonderful things, so keep going. Objectives for today, then I want to explore some physiological factors that contribute to improvement in aerobic fitness. And when I talk about aerobic fitness, I talk about the wider context of aerobic fitness, of which one of those factors is aerobic power, or VO2max. But there is the issue of performance. And the two, I'm going to try and highlight that sometimes the two don't always go together. And yet we report patient outcomes in relation to their aerobic power. But in fact, it's what they can do with the power that is the important thing. So in terms of meeting the aims, I've got 3 objectives. Quick review the value of aerobic fitness in health outcomes in cardiac rehab. Acknowledge importance of non-responders. There are people who will not improve their aerobic power. And it's quite amazing how many don't. And then consider the value of this concept of exercise economy, which is actually nothing new, but we don't talk about it as an alternative or a compensatory mechanism to people who don't improve their aerobic power. So in terms of aerobic fitness and health, this is Shrewsbury. This is where I live now, in a little town where Charles Darwin was born and educated. So up until the age of 16, Charles Darwin was born and educated there. This is our library. This is where he went to school. And by 1989, the world of his fitness science, exercise science, had shown that there was a direct link between people's essentially aerobic power and their survival. And the important thing here is that the people with the least amount of fitness or the least amount of aerobic power have the most to gain, get the greatest risk reduction. So if you, if you can run a mile in under 10 minutes, then any added benefit, you're not going to buy any more years to your life. That's basically what the data says. So it's all just enjoying yourself and beasting yourself. But, you know, in terms of your risk of reducing your mortality in the future, if you can keep running a mile in under 10 minutes, then you're doing well. So, and then Jonathan Myers in California said, well, let's see, is it the same relationship with people who have established cardiovascular disease? The other data from the Aerobics Institute in Dallas was with healthy people who didn't have any established or diagnosed heart disease. With Jonathan Myers showed that the relationship is still the same. If you take somebody with heart disease and get them fitter, you also reduce their future risk of premature death. So those are common acceptances, but this is something that's come out recently in the New England Journal of Medicine, the tortoise and the hare, and there are people doing a lot of exercise. And are they getting any more bang for their buck with this? So, in fact, this diagram comes out of the New Scientist. Because when I looked at the original journal from the New England Journal of Medicine, there was about 6 different graphs, and they went the other way. And then the New Scientist editors put it in this way. It looks much easier to understand. Essentially, once you've got to 150 minutes a week, if you continue to do moderate activity, moderate intensity activity, more and more, you gain more and more benefit. But if you're doing a lot of hours of higher intensity activity, there really isn't much more to gain from doing that. And perhaps it's that general physical activity that's insidious in everybody's days life, reducing sedentary behavior, all those factors that are probably contributing to some of those other factors beyond just your aerobic power that you get benefit. So in terms of cardiac rehabilitation, this is a recent systematic review done by Kevin, who was a really good physiotherapy student. And I said, can you just look at this? Because we're having these debates about moderate intensity versus HIIT. And I said, yep, the physiology tells us that the HIIT is superior. But do people sustain the behavior, and do people sustain the benefits? So this is, having done the systematic review, we found that there was only 3 studies that gave us data beyond the standard 8 to 12 weeks. And there's only 3 studies, but in those 3 studies, 450 odd patients, showing that obviously at the end of your typical rehabilitation program, up to about 12 weeks, the HIIT group was doing better, the aerobic power had increased more compared to the moderate intensity group. But by the time they got to 52 weeks or the year, there wasn't really much difference between so the tortoises were certainly catching up and still going up. The slight decline is probably a decline in behavior, but so we really don't know, had they maintained the behavior for the HIIT, would they still go up? Well, you guys here have the answer to that question because you've got 2 years of data. So I've put that in. Okay, but you presented this in Milan, and interesting, you know, there was statistically significant differences, but the clinical significant differences is the interesting thing that I am interested in as a practitioner. So we can add this now into this mix. I haven't added that into the meta-analysis yet, but hopefully that will be another little collaboration we can get going on. The bulk of the legwork has been done by Kevin to do all the screening and all of the papers on that. So in terms of the sustainability, it looks like if you can get patients to do moderate to vigorous intensity exercise, they're going to get benefit. Now, our sacred text for cardiac rehabilitation to justify our existence is still the Cochrane reviews. And the latest one was in 2021, and Grace Dibben is the first author. She was one of my master's students about 10 years ago in Chester. And obviously you've had Rod Taylor. He's always on these things. He's the man who justifies our existence. And at the moment, there's 85 trials on exercise-based cardiac rehabilitation, 23,000 patients in the totality, reductions in cardiac mortality, reductions in hospital readmissions, as we know, saves a lot of money, the health service. That's our main sales pitch these days for the UK. If we keep people out of hospital, we save our National Health Service money. So let's invest in rehabilitation. And finally, improve quality of life. So what we have to do is, it says exercise-based rehabilitation, but those patients are getting a whole mixture of other things. So how much is the exercise component, physical activity component, how much is that contributing to the long-term outcomes for these patients, as opposed to their nutrition, their medical management, their other behaviors like smoking, and their psychological well-being, those factors. How do those factors feed into that? So how much does improving somebody's aerobic power feed into those long-term outcomes that we measure? So I looked at the 85 studies, and this was Bindi. She was in her second year of her bachelor's degree, and they were only supposed to put in a research proposal for what they were going to do next year for their research project. Well, she ended up handing in for her research proposal pretty much the systematic review of the Cochrane Review studies. So I'd just keep that to one side. Yes, and we'll just submit your proposal. So she was just way ahead of me, which is great on this. But what the interesting thing was, of the 85 studies, only 9 of them reported outcomes of before and after using some sort of exercise test, typically a shuttle walk test, 6-minute walk test, or some sort of submaximal cycle performance. And then there was 9 studies that had maximal test protocols, mainly which used cardiopulmonary exercise testing. So I looked at those 2 sets of data to look at, well, what were the actual fitness gains in these 18 of the 85 studies? Now imagine that, the Cochrane Review, 85 studies, the first word in the title says exercise-based cardiac rehabilitation, and only 18 of those 85 studies have actually done an assessment of fitness before and after the intervention. Whereas they've got their blood pressures and their lipids and all those sorts of things going on. So what it showed was the walk tests showed a 30%, just over 30% improvement in people's, and this is aerobic fitness performance, because they're not measuring their cardiorespiratory fitness because there's no measurement of oxygen uptake. This is how long or how many shuttles people can complete, or how far they go in 6 minutes, or how long they last on the exercise bike. So they had a 30% improvement, and that's 31% improvement in performance. Where when we look at the data where they've actually measured the cardiorespiratory fitness and the aerobic power, there's a 19% improvement. So was this group different than the other group, or is there a difference between measuring performance and measuring physiology? And that's the big key in sports science all the time, is that what goes on in the lab doesn't always tell us what goes on the track or the playing field. And so this is what I'm interested in. So the possibilities of the reasons for that explanation is, within the cardiorespiratory group, there may be some non-responders. There may be people who've improved their performance, but they haven't actually improved their VO2 peak or the VO2 max. You all know that if those who've got children, if you give them a second or a third go on the standing broad jump that they have to do for primary school physical education, give them a second go and they'll go 5 to 10% further. So are some of these outcomes just patients getting more familiar with exercise and doing a better exercise test at the end because they've got more confidence, more skill, or maybe they're more economical? Are there different populations haven't got to that level? Were there different training regimes going on here? So maybe there was more outcomes because that an intervention fidelity, essentially meaning when you give patients an intervention, are they actually doing what you've written in your methods? So we said we exercise the patients at 60 to 80% of heart rate max for 20 to 30 minutes, 3 to 4 times a week. And you think, okay, well, actually, did they actually attain that dose? And we all know that in reality, there's some patients that do way over that and you have to pull the reins on them. And there's other patients who we're always having to nudge even to get them over their 40% of heart rate reserve. So these are all the issues that happen in our world. So within that, I've raised the question about the non-responders, and maybe we'll just cover the concept of what the non-responder is. So I thought, well, in the world of pharmacy and pharmaceutical interventions, there are non-responders. So I thought, well, let's pick something popular like weight loss drugs these days. And 9 to 13% of people who are taking their whatever, what in Canada, what drug are they all having? Zempic? Yes? Okay, a number of them. Well, there's going to be about 9 to 13% of them don't benefit at all. It doesn't change their weight. And are they non-responders? Did they take their medication? Assuming they took their medication, then they're non-responders. In the world of exercise training, the Heritage Family Studies, which was led by Claude Bouchard, who was from Laval University, where he started his twin studies, and he moved to the United States, to Baton Rouge, whatever the university is there, but he continued on there following data and demonstrating that up to 20% of people who do an exercise training program will not see an improvement in their VO2 peak. So they're classified as non-responders. However, there's always people out there that will argue the toss, but this is what a non-responder curve looks like. And this one goes from the least amount of response. This is the difference between before and after, all the way. So you've got the high responders on the right-hand side of the graph, the lower or non-responders or even negative responders on the left side. Some people have presented the rank order of the participants the other way around, like in the next slide. So these guys here more recently have argued there's no such thing as a non-responders. It's just that some people just didn't do enough exercise to get a benefit. And so that was the argument that's being raised. So more recently, the world of cardiac rehab, the group from the UK did the hit and miss trial. So high intensity versus moderate intensity sustained exercise. So they call it hit and miss. And this is their results. Now, their results are produced by the highest responders on the going ranked order down to the least responders. And they set a threshold of 6% improvement in VO2 peak. So if you didn't get more than 6%, you were considered a non-responder. And what they found was that there possibly was an improvement in the non-responder rate for the people who did the higher intensity exercise. But in the moderate intensity group, 61% of people did not improve their VO2 peak. And even in the high intensity group, 40% of participants did not improve their VO2 peak. So we report our outcomes as there's a significant improvement in VO2 peak and a greater improvement by those who did the HIT versus the moderate intensity program. But there's a lot of people who didn't gain much benefit. Okay, so you might know some of those people in your programs. So is it their fault, or is there some sort of genetic thing they've got? Or is there something we're not measuring? Because they certainly seem to behave like they're fitter, doing more. So one of the things Lee Ingle did as a secondary study to the hit and miss trial was he then looked at some associations, and he found that the thing that showed the most that there was an increase in the number of non-responders with older people. So the older patients tended to have a higher non-responding rate than the lower patients. Oh, somebody's popped that in there. There's some people in this room in that picture. Yeah, that's a bit of shopping in Milan. Yes. So, so this data was presented in Milan in April with the kind collaboration of this organization here, Ottawa Heart Institute. And this was Emily Gibson, who was an undergraduate in kinesiology from Ottawa. He's at Nepean University of Australia. And she came all the way to the UK to do her physiotherapy training. And this was her project for her master's in physiotherapy, so she could become a physiotherapist. She's now working not far from here. And so this was part of her master's thesis, and we looked at data from here. So we're able to get 38 patients with heart disease and atrial fibrillation. And you kindly shared the exercise testing data with us. And in this group, 55% were responders, but there was about 45% of the people didn't improve their VO2 peak. So similar to the data from the hit and miss trial in the UK, that almost half of the people aren't getting an improvement in their VO2 peak, and some of them, for some reason, got lower. So there's various reasons behind that, but the important thing is, well, what's going on? Why do some people have a really high response? And we know this on day-to-day basis. And you know that with some of the patients who you give two different patients the same dose of their beta blocker, and one person's in depression and seeing the psychologist for feeling depressed because of the side effects, or, you know, and feeling really fatigued and tired and all that. And somebody else, it barely makes any change to them. So, you know, they've got the high responders and the low responders. So the same thing happens with exercise training. So why Michael Mosley? Well, Michael Mosley he's now the late Michael Mosley, died of a tragic death on holiday. But he was a very prominent popular scientist on television. He's a GP and a hospital physician who did a lot to promote exercise and nutrition in the popular press. And we noticed that he did one of his Just One Things, which is a 10-minute snapshot on Radio 4, BBC Radio 4, on Nordic walking. Oh, it's Jennifer Reed. One morning, Sunday morning, because we listened to Just One Thing on a Sunday morning. So Jennifer, oh, better just press the pause and listen to that. So she was doing on his program on Nordic walking. I did one a few years ago on standing up when I was, and I had done a program with him on television, and called Trust Me, I'm a Doctor. And we did a study on standing up at work using standing desks and things. So anyways, he did a bit on HIIT back in 2012, and he put himself through the regime. He's got diabetes, and he put himself through the regime. And what was interesting was, this is where in the popular press, they also used the word non-responder, because Michael Mosley went through this fantastic HIIT program and his VO2max did not change. So, and there's the data, and this is on the video, so they show the data. So I thought, I pressed the pause button and freezed it and screenshotted that data. And so from the HIIT, it did not improve his VO2max, so he was noted as being a non-responder, although he responded well with improvements in his glucose and insulin control from the HIIT, and that did a good job for this. So where there was a good benefit from the HIIT program on that side, but it didn't actually show an improvement in VO2max. But if you look at the data, he actually attained a higher performance work rate. So his performance did go up, but his VO2max didn't. So I then zoomed in on the screenshot of the video. And what we're seeing here is economy. He has improved his exercise economy. He is able to do the same amount of work for less oxygen, or more work for the same amount of oxygen. So even though his VO2max hasn't improved, it actually, in relative terms, it actually has, because for the same amount of oxygen, he's doing more work. And this reminded me about economy and how important it is. And all that stuff you teach the patients about moving properly and doing things correctly and all that sort of stuff is actually really important, especially if you've got a very little amount of aerobic power. You want to use it as economical as possible. So it's nothing new. It's not just about power. It's about the economy. And obviously, these two people became president of the United States based on their marketing of improving the economy. It's not about power, which seems to be the current way around the world of promoting one's things, not doing something for the economy, but doing something for power. Anyway, part 3 then. Let's look at economy, and then we can have a bit of questions. Exercise economy is part of enhancing aerobic fitness and performance. So I'm going to go just remind us of that data from the Cochrane review, we had a 31% improvement in performance, but only a 19% improvement in actually their VO2 peak. So it's some of the, it is part of this difference, is part of that due to economy. So I got interested in running economy in 1986 because I was graduating from UBC and I was going to Loughborough University in the United Kingdom to do my master's in sports science. And I was really, really excited about it because I was a middle distance runner running on the cross country team at UBC. And I was going to the university where Sebastian Coe was a student and where he trained. And I did actually get to meet him. There was a dinner one night where he was presenting and I just found a way to, and I couldn't find the picture of me and him. I got the picture, but you know, it's not on my phone because there's no, you know, it's on a, or maybe it was my mother's, you know, sent it home and all that sort of stuff. But anyway, our first day in the lab for our exercise physiology teaching at Loughborough in September the 13th, I remember it, of 1986. So this was Clyde Williams, and he's now an emeritus professor of exercise physiology. He started up a lot of sports science in the UK. And so I was, one of the great things was I was going to get taught by him. He took us into the lab and showed us this treadmill, and he said, the most important thing about this treadmill is Sebastian Coe has been on it numerous times. And one of the things that we've measured the most was he is very economical compared to most of the other middle distance runners. He seems to use a lot less oxygen to run at the same speed. So that's what I remember about economy, and it's always stuck in my head. So if we look at some data, and this is going back to some pioneers of exercise physiology, Ed Coyle, who's doing physiology. If we look at the best predictors of race walking performance, the two strongest predictors, and these aren't the correlation coefficients, these are the coefficients of determination. And those are really strong. So between 80 and 90% of the performance is related to metabolic economy and aerobic economy. Okay, the anaerobic, what walking speed at the lactate threshold, and what is your oxygen cost for any given walking speed? Those are the two strongest. The least predictor of performance is VO2max, and yet we hail it as the big measure. Okay, and one of the things we do is we put patients waiting for surgery on the treadmill and say, if your VO2max is below 14, we can't operate on you because you've not got enough fitness to withstand the surgery. And yet you could have somebody with a VO2max of 50 who can only use 40% of their aerobic capacity. And you might have somebody with a VO2max of 11 or 12 and they fail, but they can use a lot greater proportion of it. And yet they're probably fitter for the surgery than the person. And it's quite a blunt tool. So this is an interesting scenario that we need to always consider. And then these guys did a systematic review, Carl Foster and Alejandro Lucia from Spain, and they looked at the East African runners and showed that they used 10% less oxygen to run at the same speed as the European runners. Economy, it's all about the economy, not for aerobic power. And then this is a guy named Professor Andy Jones, who I call the running economist, and he's got Kipchoge on the treadmill at his lab in Exeter in the UK, looking at his exercise economy. And he was personal sports scientist to Paula Radcliffe, who held the world record for the women's marathon between 2003 and 2019. And this is the data he's got from Paula Radcliffe. And here's her VO2max across the years from 1992 to 2003. It really doesn't change at all. But her performance continually improved until she broke the world record. And if you look at her exercise economy, the amount of oxygen she needs to run at 6 minutes a mile has continually gone down. So when she got the world record, she was the most economical. no change in VO2 max. So just think about patients, no change in VO2 max. However, are they doing better because they're more economical? So let's have a look. Is there any data on cardiac patients? So one of the students I had is a master's student in Chester University, 2014. I said, go through the Cochrane review for the heart failure and the coronary heart disease and find as many articles that did cardiopulmonary exercise testing as you can and see if we can work out whether there's economy. So 12 of the 24 studies showed an improvement in exercise economy in addition to improvements in VO2 peak, somewhere between 4 and 20%. And then this is a really nice study. Those of you who are into pumping iron and adding resistance training to your rehabilitation programs. So here's your typical heart failure rehab program. If they only did endurance exercise, they got a 5% increase in their aerobic power. They got an 11% increase in aerobic power if you're in the combined resistance training and aerobic group. And then heart rate reductions for a given maximal work rate, 23% reduction, 46% reduction in the exercising heart rate. And then we've got our economy, VO2 per watt, how much oxygen you're using pedaling an exercise bike. And again, by adding resistance training, you got greater improvements. But look at, if you got an improvement in VO2 peak of 5%, but an increase in exercise economy of 21%. So which one is contributing to the person's ability to do more exercise? Is it the power or is it the economy? So again, I've come begging for some data from the Ottawa Heart Institute. This is the 38 patients I showed you earlier, and we got the data from their exercise tests. And I've been through this twice. The second time around, I sent it to you guys, and then I sent it back. John, you missed something, you missed something. I spent 3 days, full days going back through this data. So I'm hoping it's right now. And I wrote in my email to everybody that the youthful synapses have saved me again. So anyway, on this scale here, this is the improvement in VO2 peak along the x-axis, and the y-axis is changes in your exercise economy. The differences between how much oxygen you use on the exercise bike per watt before and after 12 weeks of exercise. So there was a significant improvement in the correlation between economy and VO2 peak, but it's a negative correlation. Now that means that if you improved your VO2 peak not by very much, you had a proportionally larger increase in your economy. For those people who improved their VO2 peak by a lot, they had a much smaller improvement in their economy. So suggesting that those people who had the least amount of improvement in their VO2 peak were compensating by improving their economy. So those are the questions that are out there at the moment. That was part of the picture from Milan that I've just showed you earlier. And so those with less improvement in aerobic power appear to compensate by greater improvements in aerobic economy. But that's out there for some things to think about, but it seems to fit with the athletic population. No improvements in VO2 max, but great improvements in performance from economy. All of these studies from the Dallas Aerobics Institute, the outcome wasn't VO2 max, it was and outcomes for mortality. It was how long did people stay on the treadmill? That was a performance measure, not a VO2 max measure, because Stephen Blair, when he did those with Ken Cooper, for all those years, inviting people into the aerobics, they didn't measure respiratory exchange. They just measured how long those people stayed on the treadmill, and they correlated time on the treadmill with mortality. And that's a performance thing. So they've got lots to tease through. So anyways, Dr. Seuss, I always like Dr. Seuss to finalize because he knows everything about everything. And so size or change in the size does not always matter. It's about making the most of what you possess. And to put it in Dr. Seuss's words, you're in pretty good shape for the shape you're in. So you've got to accept what you've got and get on with life and do as best you can with what you've got. Thank you very much.
Much. I think one of the things I always most enjoy about your lectures is storytelling. I think you forget that you've been in a lecture for 35, 45, 50 minutes because it's the way you tell a story for the data. So thank you. Always enjoyable. And hopefully you've learned a few things along this story this afternoon. We're going to move into the Q&A portion. So we've got an opportunity to use the time when you're here and those online. But I'm going to leave you the role of the online.
Oh, right. Yes.
Because you're going to be standing here.
Okay.
So I will be your mic facilitator. And unless Faye is going to tell me otherwise.
So do the questions come up here?
I have to check with Faye here.
You mean I have to edit? Do we want?
I'm going to go check.
Okay.
Yeah.
Yes.
So we'll start with the mic first, and then I'll just check.
So thank you very much, Dr. Buckley, for the amazing lecture again. I had one as it was amazing as well. So my question is about one component of the exercise testing, which is the psychological beliefs, also like the patient's experience on the treadmill. And I was wondering if in the future we should consider like putting the equation or in the discussion like the reason for stopping the test, so that we can reaccrue patients for the reason, so those who are comfortable to reach out their assumed maximal and how was the performance, and those who actually felt more afraid, that they could also improve this across the training experience and they can reach. But if we can identify somehow profiles, types of patients that are familiarized, not familiarized, or those who are afraid to fall and those who are comfortable with the treadmill. So if you can expand a little bit on these.
It's a really tough question because it's a very rich amount of information in there. So one of the things is tolerance, your ability to tolerate pain and discomfort. And I'm always interested in these high intensity interval training because people volunteer to a study and hope that they'll get selected to be in the HIT group. And is there a self-selection? So one of the things I remember, here's another one of my stories, is at the British Cardiovascular Society conference, which is our national cardiologists conference. We used to do a demonstration, and we called Average Joe. Joe was a cardiologist, and he was on an exercise bike, and we had the CPEX device. Yeah, and next to him was Rebecca Romero, who had a silver medal, Olympic medal in rowing and a gold medal in cycling. And we had them side by side doing a VO2max test in front of about 100 cardiologists. And we had up on the screen, we had the CPEX data coming up live as they were performing these. And Joe got to his VO2max. It was quite a good VO2max for a 45-year-old cardiologist of 50. And he was doing his 10Ks in 41 minutes or whatever. And he finished. But what was interesting is when he got to his VO2max, he only lasted 20 seconds. Now, Rebecca Romero, we're all watching the data. She gets to VO2max and she just keeps powering on and on and on. This Olympic gold medalist in cycling. And the screams are coming out. There's 100 cardiologists cheering her on to keep going. Well, she got her VO2max. She went for 2.5 minutes at max. And it's just the ability they just got a screw loose. So they don't have a pain threshold. They don't have this automatic sort of limiter in their body that protects them from killing themselves almost. So there's a physiological input into people's psychological behavior. And we know that stress and depression heighten your sensitivity to pain and all of those things. So it's a really tough question to answer. So, and then we stick confidence in there, we stick fear in there, and we've got these physiological stimuli coming in on top of those. So it is really difficult to tease through on that, but it's a great qualitative study to maybe.
Yeah, because
How many people are you going to need to get enough data to?
yeah, because what we see is some patients, depending on their personal beliefs, even before step into the test, this can be a totally different experience.
Yeah.
So making sure we have a good preparation, like in the research, we can do a very individual approach because we need to repeat the procedures, but
Yeah.
in actual care, it's really important, like to invest on education, so patients understand the aim of the test, how it's gonna work, so they can expect and prepare or change the previous beliefs, so they can actually put their best they can. Of
So
course,
maybe they need some time as getting some experience doing exercise before you test them,
that's a paradox. That yeah,
right? There needs to be a pre-testing period of training, and it's psychological, physiological, all that sort of stuff before you actually test them.
thank you.
Good question. Sorry, I didn't answer.
Okay, I'm going to move to the online, then we'll
Oh,
come
you've
back.
got them.
So if anyone in person has a question, just raise your hand afterwards and I'll come to you. We've turned on, just John, so you know, we've turned off the slides in the front because there's a request to see your face during the Q&A period. So just know that you are on the hot seat right now.
Oh, right. Okay.
Okay, I'm gonna promise you a cup of tea at some point during your visit if you can name who the question that this is from, the person this question's from.
Cup of tea.
Cup of tea. I'm really going all in. So based on this question, if you can name who posed this question, extra cup of tea is coming your way. And it's going to be a green tea, not English
Green
breakfast or Earl Grey.
Is it an international question?
Okay, here's the question. Two of them, actually.
It's not you, is it?
Do you also think there's a compensatory effect in these trials whereby those who are non-responders or negative responders may be also more likely to go home and sit more and replace previously active time thinking that they undertook their exercise training? We have done some work to suggest that reducing sedentary behavior can improve fitness. Do we know what they're doing outside of cardiac rehab?
It's not Stephanie, is it?
You've guessed it. You've guessed it. So I'm going to leave you to answer, to think.
Oh no, she's right. And you've shown that in your studies that yes, obviously it's not just the training program, it's the whole lifestyle activity. And often what we assume to be light activity for many people is if you've got some of your heart failure patients or got low capacity, any activity is probably fitness training for them. And so they could be then possibly, the question is, are they physiological non-responders or are they training non-responders? And those, yeah, I think it's all in there. But what I'm interested in is what the data has shown that for whatever reason people were lower responders, there seemed to be this association with economy. So yeah, that's what I'm trying to keep in my head is I'm not actually worried why they didn't respond. I'm just looking at the facts.
So this leads to her second question. Does aerobic economy also predict future health/mortality?
Well, it depends how much is it. Yes, it's a good question. And I was going to those questions from the Aerobics Institute where performance was the outcome measure, not aerobic power. And so we know that economy is part of performance, but we've got fear, we've got anxiety, we've got skill, we've got all of those things as well in there. And they're all compounding. So yeah, I don't think I can answer that question, but economy is certainly looks like it's going to be one of the contributors. Do I get a cup of tea, Stephanie? Monday night, we'll get you a cup of tea.
Other questions from those in the room? Oh, you get a bravo from her.
Hi, John. Thank you very much for your talk. You're always wonderful to hear from. So I'm going to tap into your many, many years of experience here with this question. So
Could be bad experience, you know.
that's true. That's
Experience
true.
isn't always a good thing.
I know. Okay. Yes. So I'm just wondering, besides the fact that we might not be measuring what totally matters, do you see, or what do you perceive to be the greatest challenge facing sort of cardiac rehab as a whole? So the science of cardiac rehab, the practice of cardiac rehab, what do you see as being the biggest challenge that we're all facing?
Well, to me, rehabilitation is a behavioral therapy. It's not a physiological game. It's not an educational game. It's a behavioral therapy. And I still don't think that we are really addressing that, both in terms of the people who decide, for whatever reason, not to take up the invitation, and even people who take up the invitation, who give it a go. I just find that that is the area that most cardiac rehabilitation professionals had the least amount of training, proper training. And I've done some stuff on motivational interviewing, which really just proved to me a lot of the things I say to patients is actually counterproductive to changing their behavior. And it scared me a lot. And so I think that being a psychologist yourself, I really don't, because when you listen to people talk about cardiac rehabilitation, if you go to a conference and you listen like at the bar having a glass of wine or something, they ain't talking about physiology and all that stuff. They're talking about service limitations and the challenges of dealing with patients who come from poor backgrounds or different ethnic minorities or all these sorts of things and all that stuff. And it's all behavioral. And I think that's still our biggest challenge. And then if we've got politics and on top of that, you know, in countries that are developing, and that was one of the aims of the ICCPR, is as cardiology came online into these developing countries, our words in our charter was rehabilitation should be obligatory as part of that package. So I think that's as best I can answer for that question. I'm not getting very well. I'm not giving any answers. I think actually when you get older, you just don't say anything.
Yeah, this is
You know less about more.
answer period.
You know more
of the
about less. Yeah. Yeah. You know more about less. Yeah.
Well, based on the comments I'm seeing come in, I think you're answering the questions today quite
Okay.
well, and many have enjoyed your presentation, which is not surprising. We have a question from Richard, which is, what is a better predictor of longevity? Max heart rate during exercise or VO2 max during intense exercise? And I think I would probably extend that question to say, if you had to suggest one variable, one parameter, one measure, what would it be for
max
patients?
heart rate during exercise or max?
Or VO2 max during intense exercise as a better predictor of longevity?
Well, I'd have to go with VO2 max because if I'm really, really unfit, I can get to my maximal heart rate quite quickly. So I wouldn't use it. To me, it's what you're doing at max heart rate. So if you're only made it to 30 watts on the exercise bike and you're at max heart rate, that's not a very good thing. Or if you're at 300 watts, like a Olympic cyclist, then so it has to be VO2 max, I think. If I had to go on television on a program and who wants to be a millionaire or whatever, I think I'd go with VO2 max on that one.
Okay, any more questions for those in person? The comments coming in. Oh, we've got more questions actually flowing in online. Is there anyone else in person that wants to put him on the hot seat while he's here? Okay. Question coming in is, how does the Auto Heart Institute select study participants? So not necessarily specific to your talk, but in general, yes. And a question probably overall for those that are listening to some of these presentations. And again, indeed, how do you select study participants?
So how do I personally select study participants? Well, I think that the whole world of cardiac rehab or any behavioral therapy intervention, whether it's physiotherapy, occupational therapy, psychology. We can't just, it's not like a drug trial where we can say, can you participate? And it's quite an easy thing to do. Whereas entering into a trial where people have to do behaviors that they're not used to doing, and they can't really, and they haven't had any benefits or haven't perceived any benefits from them in the past, then I do worry we have this problem of self-selection. But the upside of the self-selection is, in though I showed you, the least always have the most to gain. Now, if we're getting 5 and 10% improvements in people who decide to participate in a trial, we are probably taking the better people, the worried well. And if they're getting a benefit, just think how much benefit somebody would be getting if they were of the other people who didn't volunteer. So it gives me some comfort. And I do worry that cardiac rehab gets a hammering for the quality, for its outcomes. Because I think what we're doing is we're not getting as much benefit in our results because we're already taking people that are probably well and fit into our trials by self-selection. So there is a big bias. I don't know how you get about it, but this whole world of wearable technology may be part of the answer. That if people can wear stuff and they can do whatever they like without an exercise prescription, and they just get on with life, we may be able to measure people's activity levels and their levels of fitness. And that's what we're doing in there with the accelerometer on people's feet. We can know what intensity they're exercising to as well as how much they do. So maybe that might be the answer.
Thank you. We've got more comments coming in thanking you for your presentation. But if there's no more on the floor coming in, I think we will take the opportunity again to thank you for your presentation. Thank you for coming to spend this week with us. Those that have not met John, please take the opportunity to find him. He'll be on the track this week, recruiting participants for a study that we're collaborating with him on. And his PhD student, Sam, will be here next week. So you'll see one of them over the course of the next 2 weeks. So don't be shy, introduce yourselves, pick his brain. If you didn't answer your questions during the answer period, you could do that. And I think I will close by those that are online in person. We have our first cardiac rehabilitation round starting off September 15th is Dr. Trine Moldholt. She'll be joining us virtually from Norway. Her presentation is focused on women's heart health. It's physical activity exercise through the reproductive years. So if you haven't seen it yet, I would encourage you to look online. The Heart Institute website has already posted the presentation. We've shared it internally, but it's open to anyone, internal, external, regardless of where you're located across the globe. So I would encourage you to join us September 15th at noon. And with that, we will bring this session to a close and thank you for making the trip here to Canada, John, and we will look forward to our next few days with you. Thank you.
Thank you.